During a thoracentesis procedure through an intercostal space, the patient should be seated, if possible, or lying in the lateral decubitus position. The arm on the side to be punctured should be elevated, and the patient's hand placed on the back of their neck, thereby causing a rotation of the scapula and enlarging the intercostal spaces. Being able to predict the position of effusion in a dependent position is a major advantage when the patient is scanned in an upright position. Pleural ultrasonography is more difficult to perform in a supine patient. However, this is usually the case for critically ill patients whose hemodynamic status and support devices prohibit an upright position. In the supine position, effusion settles into layers posteriorly, with the lung assuming an anterior position in the thorax. This slide shows an ICU patient well positioned for pleural ultrasonography. The head of the bed is elevated and the arm abducted. Thoracentesis is routinely performed using a freehand technique after marking the site for needle insertion. The needle does not have to be observed in real time using the ultrasound transducer. Identifying the patient's chest wall thickness using a high-frequency probe is useful as it indicates how far the needle can penetrate before entering the pleural space. Note that pressing a probe to the patient's skin creates an indent, especially in patients suffering from edema. Needle insertion must consider this and may thus require a different depth of penetration than was actually measured. Usual thoracentesis technique recommends that the puncture is made as close as possible to the superior margin of the inferior rib. However, this technique may lead to collateral intercostal artery laceration and considerable bleeding. The author of the paper on this slide suggests that the puncture should be made in the middle of the intercostal space, thereby reducing the chances of lacerating the collateral intercostal artery. It is important to align the insertion of the needle with the ultrasound plane. A is appropriate, B is inappropriate. The sizes of the intercostal and collateral vessels decrease towards the mid-axillary line, after which they increase again towards the parasternal region. In view of this, the mid-axillary line is considered the safest place to implement techniques that use the intercostal space to access the thoracic cavity. This slide shows the safe puncture zone for thoracentesis in green and the unsafe zone in red. In risky situations, it may be safest to check for the presence of an arterial signal at the anticipated puncture site in advance. The image on the right shows an example of this. This slide shows another example. This slide is a reminder of the recommended steps for performing a chest puncture assisted by ultrasonography. Performing ultrasound-guided thoracentesis requires that the patient is properly positioned. Proper positioning with a clear field of action is essential to success. Firstly, the diaphragm must be identified, and then the best site for puncture must be selected and marked. The low-frequency probe used for those procedures should be swapped for a high-frequency probe to obtain a superficial image and measure the chest wall thickness. Thoracentesis should be performed immediately after the patient's ultrasound examination and without moving the patient. Any movement could cause the effusion to shift in relation to the planned insertion site. The optimal chest tube size for managing pleural diseases is still a matter of debate. The British Thoracic Society guidelines suggest that in cases involving pneumothorax and malignant or infectious effusions, including empyema, a small bore chest tube inferior to 14 French is usually adequate. Using chest tubes superior to 20 French is recommended in the following situations: when there is a clinical concern about the presence of an ongoing air leak or a significant risk of one, as in a traumatic pneumothorax, an iatrogenic pneumothorax due to barotrauma during mechanical ventilation, and cases of hemothorax or postoperative drainage of the chest cavity. Smaller chest tubes may result in significantly less pain than larger ones.
After crossing the parietal wall, in the presence of a pneumothorax, direct the drain anteriorly towards the sternum. In the event of pleural effusion, direct it posteriorly towards the diaphragmatic cul-de-sac.
Thoracentesis is considered safe when the intrapleural distance is more than 1.5 centimeters deep across 3 intercostal spaces. In risky situations, caution suggests trying to locate the patient's intercostal arteries, measuring chest wall thickness precisely, identifying the lung surface abutting the effusion, and finally, placing a central venous catheter guided by ultrasonography. This slide shows an example of re-expansion edema after a rapid drainage of a very large pleural effusion. In this situation, drainage should be at most 1 litre gradually during the first hour. Even using ultrasonography, some chest puncture procedures remain difficult, as in this case of morbid obesity.